Hello friends, greeting from Rfatutors, your mentor this side with the Green Top Guideline of the day. Today we are here to tell you about the diagnosis and management of ectopic pregnancy. The Green Top Guideline 21, published in November year 2016. An ectopic pregnancy is any pregnancy implanted outside of the endometrial cavity. In the United Kingdom, the incidence is approximately 11 in 1,000 pregnancies, with an estimated 11,000 ectopic pregnancies diagnosed each year. The incidence of ectopic pregnancy in women attending early pregnancy units is 2 to 3%. Risk factors for ectopic pregnancy include tubal damage following surgery or infection, smoking, and in vitro fertilization. The purpose of this guideline is to provide evidence-based guidance on the diagnosis and management of ectopic pregnancy. This guideline will cover the following ectopic pregnancies like tubal, cervical, cesarean scar, interstitial, carnal, ovarian, abdominal, and heterotopic. Unfortunately, women still die from ectopic pregnancy, friends, with 6 maternal deaths reported between 2006 and 2008. However, the case fatality rate has decreased over recent years, suggesting that earlier diagnosis and treatment may have made an impact. Transvaginal ultrasound is the diagnostic tool of choice for tubal ectopic pregnancy. Tubal ectopic pregnancy should be positively identified if possible by visualizing an internexal mass that moves separate to the ovary. A serum progesterone level is not useful in predicting ectopic pregnancy. A serum beta human chorionic gonadotrophin level is useful for planning the management of an ultrasound visualized ectopic pregnancy. The following ultrasound criteria may be used for the diagnosis of cervical ectopic pregnancy: an empty uterus, a barrel-shaped cervix, a gestational sac present below the level of the internal cervical os, and the absence of sliding sign and blood flow around the gestational sac using color Doppler. A single serum beta HCG should be carried out at the diagnosis, an important single best answer. Clinicians should be aware that ultrasound is the primary diagnostic modality using a transvaginal approach, supplemented by transabdominal imaging if required. The defined criteria for diagnosing the cesarean scar pregnancy on TVS have been described. Magnetic resonance imaging can be used as a second-line investigation if the diagnosis is equivocal and there is local expertise in the MRI diagnosis of cesarean scar pregnancies. No biochemical investigations are needed routinely. The following ultrasound scan criteria may be used for the diagnosis of interstitial pregnancy, which is empty uterine cavity, product of conception, gestational sac located laterally in the interstitial intramural part of the tube, and surrounded by less than 5 mm of myometrium in all imaging planes, and presence of interstitial line sign. Sonographic findings in 2-dimension can be further confirmed using 3-dimensional ultrasound where available to avoid misdiagnosis with early intrauterine or angular pregnancy. Supplementation with MRI can also be helpful in the diagnosis of interstitial pregnancy. A single serum beta HCG should be carried out at diagnosis to help with management. In some cases, a repeat serum beta HCG in 48 hours may be useful in deciding further management. A single serum beta HCG should be carried out at diagnosis to help with management, and in some cases, a repeat serum beta HCG in 48 hours may be useful in deciding further management. The ultrasound scan criteria, friends, which is for the cornual pregnancy, it is visualization of a single interstitial portion of the fallopian tube in the main uterine body, gestational sac, product of conception, seen mobile, and separate from the uterus, and completely surrounded by myometrium. That is the buzzword that differentiates cornual with interstitial. I will give you my tables, I will give you the algorithms for the management, and lots of gift slides. A vascular pedicle adjoining the gestational sac to the unicornuate uterus. Remember all these lines because this comes as an exam question. However, we do not have any specific agreed criteria for the ultrasound diagnosis of ovarian ectopic. A single serum beta HCG should be carried out at diagnosis to help with management. In some cases, a repeat serum beta HCG in 48 hours may be useful in deciding the further management. Defining the ultrasound criteria can be used to diagnose an abdominal pregnancy. MRI can be a useful diagnostic adjunct in advanced abdominal pregnancy and can help to plan the surgical approach. A high index of suspicion is based upon an elevated serum beta-HCG level in combination with ultrasound findings. A heterotopic pregnancy is diagnosed when the ultrasound findings demonstrate an intrauterine pregnancy and a coexisting ectopic pregnancy. A laparoscopic surgical approach is preferable to an open approach, and in the presence of a healthy contralateral tube, salpingectomy should be performed in preference to the salpingotomy. In women with a history of fertility-reducing factors, salpingotomy should be considered. Expectant management is an option for clinically stable women with an ultrasound diagnosis of ectopic pregnancy and decreasing beta human chorionic gonadotrophin level, initially less than 1500 international unit per liter. If a salpingotomy is performed, women should be informed about the risk of the persistent trophoblastic with the need of serum beta-HCG levels follow-up. Systemic methotrexate may be offered to suitable women with a tubal ectopic pregnancy. Medical management with methotrexate can be considered for cervical pregnancy. Surgical methods of management are associated with a high failure rate and should be reserved for those women suffering life-threatening bleeding. Women diagnosed with cesarean section scar pregnancies should be counseled that such pregnancies are associated with severe maternal morbidity and mortality. Medical and surgical interventions with or without additional hemostatic measures should be considered in women with first trimester cesarean scar pregnancy. The non-surgical management is an acceptable option for stable interstitial pregnancies. That is, expectant management is only suitable for women with low or significantly falling beta-HCG levels. The surgical management by laparoscopic corneal resection or salpingotomy is an effective option. Alternative surgical techniques could include a hysteroscopic resection under laparoscopic or ultrasound guidance. The definitive surgical treatment is preferred for the ovarian pregnancy if laparoscopy is required to make the diagnosis of ovarian ectopic pregnancy. Systemic methotrexate can be used to treat ovarian ectopic pregnancy when the risk of surgery is higher. Advanced abdominal pregnancy should be managed by laparotomy, and for an early pregnancy, laparoscopic removal can be done. For heterotopic pregnancy, the intrauterine pregnancy must be considered in the management plan. Methotrexate should only be considered if an intrauterine pregnancy is non-viable or if the woman does not wish to continue with the pregnancy. The surgical removal of the ectopic pregnancy is the method of choice for hemodynamically unstable women, a very important extended match question, and offer NTD prophylaxis as per national protocol to all RHD negative women who have surgical removal of an ectopic pregnancy or where bleeding is repeated, heavy, or associated with abdominal pain. We will follow the NTD recommendations Green Top guideline in this regard and not the Green Top guideline ectopic. Women with previous history of subfertility should be advised that treatment of their tubal ectopic pregnancy with the expectant or medical management is associated with improved reproductive outcomes. Women receiving methotrexate for the management of tubal ectopic pregnancy can be advised that there is no effect on the ovarian reserve. Women should be advised whenever possible of the advantages and disadvantages associated with each approach used for the treatment of ectopic pregnancy and to participate fully in the selection of the most appropriate treatment. Providers of early pregnancy care should provide a 7-day early pregnancy assessment service with direct access for women referred by general practitioners and accident and emergency department. Women should have access to all appropriate management options for their ectopic pregnancy. The clinicians undertaking ultrasound for the diagnosis of ectopic pregnancy must have received appropriate training. The Appendix 2 of the talk article, the single dose protocol for intramuscular methotrexate, day 1, day 4, and day 7. The contraindications to methotrexate. Some important exam points from this Green Top guideline are the types of ectopic, the distinguished criteria, the management of ectopic, the expectant, the medical, and the surgical. Yes, these all are important for your extended match question and early pregnancy single best answers. Best of luck from entire team of RFA tutors. I thank you for joining us today. See you next time. Until we meet again, take very good care of yourself. Bye bye.